Hello? Samuel?
Hello. Good.
Hello.
Hi.
Maybe my camera is not on.
Prof, your camera is not on.
Yeah, I'm trying to turn it on.
Okay.
Okay, we just wait a while.
Hello, greetings to you, everyone.
Okay. I think it's on now.
Great. You're welcome, sir.
Hello, everyone.
I don't know where you are and what the time is there, but I just want to say greetings to you from Ghana and welcome to the Rare Diseases Ghana Initiative Newborn Screening Webinar. Speakers, guests, and staff and volunteers of RDGI, we welcome you all to this learning experience. I would indulge you that if you are not speaking, please mute your microphone so that we can minimize the echoing. Please. Thank you very much. Speakers, are we good to start?
Yep.
Great. Ladies and gentlemen, you are, as said earlier, you're welcome to today's webinar. The whole of September, the RDGI team has been working hard to create awareness about the importance of newborn screening as a resource in identifying inherited genetic conditions. We are very fortunate today to have key resource persons from around the world to support us to culminate this great month in this webinar. At this moment, I'd like to introduce the founder and executive director of the Rare Disease Ghana Initiative to give us his welcome address. Ladies and gentlemen, please help me welcome Mr. Samuel Biafide.
Yeah, thank you very much, Deborah, and thank you everyone who has made time to join in our webinar this afternoon. I want to thank the speakers for all the time and for accepting to speak in the webinar. In fact, I deem it a great pleasure that you, out of your busy schedule, you made time for this important conversation. I would want to briefly touch on a little bit of what Rare Disease Ghana initiative, what Rare Disease Ghana stands for, and what we are so far, and why we think that newborn screening is a vital tool for our work, and why we are in great support of newborn screening as an organization. Rare Disease Ghana started in 2017. Mali was registered in 2018. When I met a family living with an undiagnosed medical condition, a syndrome. Family still remains undiagnosed, but seeing the challenge in the system and difficulty in patients and basic healthcare and social services, we come which is probably leading advocacy for persons living with undiagnosed genetic and rare diseases. As we may be aware, rare diseases reflect a group of conditions with low prevalence, which often accompanies individual deaths and causes functional and structural abnormalities and disabilities. There are about 7,000 rare diseases, which affects, of which about 80% are genetically inherited. Majority of the people, greater percentage are children, and so far about 350 million people have been noted to be affected by rare diseases. Some of the classical features, challenges of rare diseases is in relation to getting diagnosis. Most people live for a greater part of their lives before diagnosis arrive. Usually patients have to struggle through different healthcare systems, different professionals getting multiple misdiagnosis. And may be able to provide some support to them. And the delayed diagnosis results that for rare disease have access to treatment. The few who have developing countries and African treatments. And in spite of all of these, the burden goes to the family and the caregivers who to a specialist is very difficult. You have to move from one facility to the other, and it becomes so difficult and very stressful for the families. And as a result, there is a need for us to have a system that will seek to provide care for those affected. Even though individually the conditions are rare, and that you get a very small number of people affected by individual rare diseases. If you put them together, about 7,000 rare diseases, we are talking about a large number of people who may be affected. And so the goal of Rare Disease Ghana initiative is to be able to provide that enabling environment for those who are affected by rare diseases to thrive, to also live a fully functional life where necessary. And so without action, we know that there will be other people who may be born with a worse form of the condition if we don't take steps. And this is one of the reasons why we need to diagnose early, and for that matter, the need for an intervention like newborn screening to be able to condition, and then having to, for example, long-term complication which could be prevented. And so we need to intervene in that way. And that's why, as an organization, we are very committed in making sure that this newborn screening becomes a reality in the country. There may be inappropriate behaviors, and we have seen that happen, a lot of abuses in the community, and people resulting in inappropriate behaviors and a huge stigma. We need to help people who are affected to also feel life we may be able to support. And so we need to strengthen the healthcare system and be able that is needed. So as an organization, our mission is to improve Hello, can you hear me?
Yes.
Okay. So our mission is to improve the well-being and the quality of life of persons affected by rare diseases. This is basically what we stand for. So when we are hoping to be the leading organization for health professionals, patients, their caregivers, the researchers, and industry, and be able to serve as the voice that coordinates rare disease in Ghana. We are basically a non-profit alliance organization which creates the platform to be able to address the entire gap in the rare disease management, the entire continuum of rare disease management. So our activities are focused more on being able to engage in activities that create increased knowledge. And so we do a lot of educational initiatives, training health professionals, doing sensitization campaigns, doing like rare disease, like the newborn screening campaigns, and undiagnosed disease day, honoring rare disease day, and being able to use our social media and other platforms that we have to be able to create awareness on rare diseases. We also promote and advocate for early diagnosis, and so we have a project that we are running with several stakeholders that seeks to provide diagnosis for rare diseases and be able to offer cost-effective genetic testing to patients and lead genetic tests. We also is providing some that could be beneficial to be to help patients families who may be affected to understand their condition and how they can cope and move on in life through our care coordination program, and also be able to ensure that patients have access to treatment our drug. And then we also are involved also in community building and engagement, establishing communities that will help to rare disease care group under Rare Disease Ghana initiative that connects patients living with rare. And then we have the professional network connecting health professionals race disease to belong to a community. And then we have Alliance of Ghana to be able to bring in peers and other support organizations to work collaboratively. And then we have the foundation or corporate partners who support rare diseases care and treatment in Ghana. And so we bring these communities together so that we'll be able to achieve, we'll be able to provide comprehensive care. It may take forever, if I have to, it may take all the time. So I want to thank you all for making the time. And today I am very optimistic that the newborn screening discussion is going to be very fruitful and is going to increase our knowledge and add more to what we hope to achieve in the future. And I hope you enjoyed today's discussion from our experts. I am not an expert. We have experts here who are going to talk about newborn screening and give us so far and what the direction should be for us. I wish you all the best, and I encourage you to ask questions, and where necessary, we are here to support in any way we can. Thank you very much, and I wish you all the best in this discussion.
Thank you very much, Samir, for that impressive work that RDGI has been doing in the short time it's been in existence. Indeed, organizations like RDGI are a gift to the families and individuals living with rare diseases in Ghana. And we only hope that we can only get better as the years go by. Ladies and gentlemen, our next speaker, I was teasing him earlier that he is a walking encyclopedia on newborn screening. Professor Bradford L. Jr. Thirell is a retired professor from the Health Sciences Center of the University of Texas. Prof has more than 50 years of international consultation for newborn screening experience. Ladies and gentlemen, we are so lucky that Prof is here to share his experience with us. Prof will be talking on the subject, lessons learned from worldwide newborn screening programs. Ladies and gentlemen, please help me welcome Prof. Thirell.
Thank you, Deborah. I don't see how I can get my slides up. There we go. Okay. So thank you and welcome. Okay. I've got it. Can you hear me okay?
Yeah, we can hear you okay.
Great. Okay, well, welcome. Thank you for the introduction and welcome from Texas. The next few minutes, I want to talk a little bit about newborn screening, but my slides aren't moving forward. There they go. So what I'm going to do is talk a little bit about what newborn screening is, briefly review what's going on around the world, and then discuss about 10 of the most important barriers to sustaining newborn screening in developing economies, and I'm going to give you some examples of solutions in other countries. So first, let's talk about what newborn screening is. It's a system that usually begins with an interested individual or group of individuals who care about improving health. And you just heard some of that discussion. It evolves in individual, cultural, economic, and political environments. And it's successful because of the efforts of dedicated screening staff members and concerned professionals. It's a system that includes a lot of different components. There are advocates and opinion leaders, policymakers, doctors, laboratory people, administrators, hospitals, specialists, insurance companies, family members, and then politicians and others. So newborn screening occurs all over the world, and the basic barriers are really the same. They just vary by degree. So there are bigger barriers in the developing countries than there are in developed, but the same barriers exist. And we're going to talk about those. They have to do with financing, technology availability, program logistics, education, cultural sensitivity, and political and community support. So let me just show you a little cartoon of what the system looks like. It begins with physicians learning about the conditions that we're screening for, and they in turn teach parents. Then a baby is born, and the baby is usually born in the hospital, but not always. A blood specimen is collected. It's taken to a screening laboratory somewhere, and the laboratory technicians work on the test. The data is reported back into the system. Sometimes it feeds other databases, and sometimes usually there is a coordinator who follows up those babies who need to be tracked down for further testing. And the whole idea is to get the baby into a medical home, get them with services, and do long-term follow-up so that they lead a successful life. Now, if you were doing one screening, it would look like this, one disease. If you add a disease, it just takes tweaking the computer a little bit, adding a few more people, adding some more laboratory people, adding a little more follow-up, and then you've got to teach the parents and the physicians about the diseases. Some cases, people have added hearing screening. The same thing happens. Sometimes the data are put on birth certificates and sent back to other databases. Some people are doing congenital heart defect screening. Again, you just tweak the system a little bit, add a few more people, do some more education, and the system continues. So the basic concern here is developing an infrastructure which will work for everything. Now, I'm not going to spend a whole lot of time going on what's going on in the world, but if you go back to Journal of Inherited Metabolic Diseases in 2007, there are reports on each different section of the world, basically what was going on in 2007. In addition, there's a paper in there from the International Atomic Energy Agency, which gives a map and gives a discussion of how they funded different programs over the years. And I put this here so you can see that there has been funding given to countries in Africa, predominantly for hypothyroid screening, but that never has seemed to take off. Nonetheless, the International Atomic Energy Agency did put some money into the program at some point. Now, we've updated these data from 2007 with a report in 2015. The same authors of those 2007 papers contributed, so that if you go look for this paper in 2015, you'll get a general view of what's going on around the world even today. It's pretty up to date. So let me just show you how the history has progressed in terms of screening. I'm going to start off with a gray world where no screening happened before 1960, or maybe some urine screening, but no blood screening. And then I'm going to add countries in red as we go through the years by decade. So in the 1960s, the US, Canada, some of Europe, Australia, New Zealand began screening. And then slowly we expanded into other parts of Europe, Latin America, then into Asia in the 80s, a little bit beginning in South Africa. Then along came a couple of programs in Africa in the 90s, in Ghana, and I can't remember the other one, but anyway, in Ghana. And now you can see this is about what it looks like today, with the exception of there are some pilots in Africa, which I'll talk about in a minute. So let me just show you some of the diseases that are being screened for. And I'm just going to limit it to these 5 or 6, but there's at least 50 different diseases being screened in some programs in the world. So if you look at congenital hypothyroidism, that turns out to be the #1 condition in the world, and generally because it's a relatively high incidence in the entire world population of about 1 in 2,000. So all these things that are marked in darker red are the ones that have greater than 50% coverage, and the ones in cross-hatching are less than 50%, and gray has essentially no coverage. And that's the way it's going to be on all these maps. So there's hypothyroidism, there's PKU, Phenylketonuria, that was actually the first condition started with newborn screening back in the 60s. There's galactosemia. Here's congenital adrenal hyperplasia. Here's cystic fibrosis. So you can see there's a number of things going on, mostly in the developed world. Various metabolic conditions now being done by tandem mass spectrometry. So they're expanding the battery to up to 50 different diseases with mass spectrometry. And then if you look at hemoglobinopathies, you see that there's a lot of action going on in Africa at the present time. And that's what we're going to talk a little bit about this morning. If you look at the world in general, only about 35% of the babies in the world are screened for anything, basically one condition or more. And so that's because there's such a large population not being screened in Africa, essentially, and parts of Asia. So there are a couple of questions that come up then. You know, should newborns from developed countries be deprived of the opportunity to be saved from mental retardation or death just because they're in a developing country? And therefore, should the newborns from developing countries be deprived of newborn screening? So Bob Guthrie, who's the father of newborn screening, used to say, you know, the developing world can least afford babies that aren't healthy and don't have the possibility of leading a fully healthy life. So I've done a little work on barriers over the years, and we're going to talk about barriers in a minute. Here's a couple of papers that you may want to take a look at if you want to look at details on the barriers. Dr. Padilla from the Philippines and I have done quite a bit of work, especially in Asia, and you'll see that in some of the slides that are coming up here. The Philippine program is one of those from a developing country that turns out to have been very successful and even is represented as a model to some of the developing programs because of the things that they've been able to do. So the 10 different things that I'm going to talk about are listed here, including, you know, leadership, planning, education, different types of support, policy development, administration, evaluation, and then institutionalization of the program. So let's first talk about leadership. It usually requires some sort of passion, and the person who's the leader or the group who's the leader must be able to clearly convey their ideas and to motivate others and to get the point across. And I think that's what you're seeing here today with this seminar. So there are many different groups around the developing world that are working on this. Here's a group in Middle East and North Africa that started meeting in 2006. I've been to India with the US State Department 2006 and Vietnam in 2010 and other parts of the world as well. So that eventually I've been able to put together a map of Asia, and I'm beginning to work on a map of Africa showing the individual or groups of individuals that were most influential in getting newborn screening going in these areas. So I hope the next time I talk to you, I'll have a map of Africa that I can show you. Because here is the first Pan-African workshop in newborn screening that we just held last year in Morocco. There were 11 countries in Africa that were able to send representatives, although more were interested. The logistics were just not such that everybody could be there. But at any rate, this is the group, and you can see the flags of the different countries. Dr. Frimpong was there, and you'll be hearing from him in a few minutes. Dr. Padilla from the Philippines and I were both there. Other leadership, you know, here's Sam on the internet. If you go look at the YouTube, you can see things about rare diseases in Ghana. You can see pictures of student volunteers and emphasis on Newborn Screening Awareness Month. And you can even see Dr. Frimpong in a number of different pictures of and discussions of work that he's been doing. In terms of planning, which is the second thing on my list, the most important is to get good leadership. The second thing is you got to do is sit down and do some planning. So you can create momentum through visionary ideas, but you've got to have a systematic approach. You've got to sit down and think it through. Otherwise, you're going to end up 20 years from now not being where you want to be. So the main objectives of this Pan-African working group are to help the countries with existing programs refine and expand, and to work with those countries that don't have newborn screening to initiate programs. And so we've published a paper recently, it's just come out in the last couple of months, and you might want to look at this one, talking about what's going on right now in African countries and trying to work on empowerment through collaboration. And in that paper is something called the Rabat Declaration. The meeting was in Rabat. And so in order to have some output that we could take back to policymakers, there is a declaration which basically talks about everybody needing to screen for at least one condition, primarily sickle cell across Africa, and that countries need to develop a screening system within their public health system. There are many, many other suggestions for actions and collaborations, and I suggest that you get a hold of this publication, and I can send copies to Samuel when this is over, and he can distribute them if you want. There are also studies of other regional collaborations, like in the Asia Pacific region and like in the Middle East and North Africa. Now, education is probably the biggest and broadest concept that we'll talk about. There's all sorts of different types of education, primarily three different groups: parents, professionals, and decision makers, and they all take a little bit of different educating. So I'm going to give you a little bit of information here. Here's a book that we've put together for the International Atomic Energy Agency, talking about how to start screening for hypothyroidism. There are many, many different pamphlets from different countries talking about how their programs are run, even in Iran. There are classes that people have used in different settings. Here's one from South Africa, where they talk to the mothers who are coming into the clinics, and in such a way that when the baby is born, the mother won't leave the hospital until she makes sure that somebody's taken a sample on her baby. Radio interviews. The Philippines, I thought this was kind of unique until I went to South Africa and they asked me to be on the radio. And then I went on the internet and I found Dr. Frimpong is all over the internet with radio. So radio is a good way to do things in the developing country, and also television. Now, in some cases, like in the Philippines, religion plays a big part in decision making. And so there's a Catholic TV station, and they've been able to get newborn screening discussed in that format. Not only that, the president of the Philippines used to have a monthly hour meeting, and they got newborn screening to be discussed there. And if you'll notice, there's a flip chart off to the side here, and they have these flip charts available to give to policymakers so they can go through and look at what's going on in newborn screening. Now, I thought this was unique until I went again on the internet, and there's Dr. Frimpong. So television is a big part of education about sickle cell awareness in Ghana. And Dr. Frimpong is really a rock star. I found him about 50 different places. So I'll just quickly run through these because he's going to be talking in a minute. I don't want to steal too much of his thunder, but he's been really a big proponent of sickle cell screening throughout Ghana. And it's good to have him here this morning. There are many different collection videos and videotapes available, different programs, different languages. Those are usually provided to hospitals or birthing facilities, showing them how to take a proper sample to send it into the laboratory. Here's one from Korea. That was one from Vietnam. There's all sorts of educational materials available, again, on the internet. Here's the Thai program. They've got all sorts of things for parents. Some of this material has begun to be developed in Ghana as well. Giving seminars to nurses. I like to show this picture because when you go to the Philippines and give a talk and they want to take a picture, they sort of organize it by height, and they put the tallest in the center, and then they go down on the outside. And I thought it's kind of cute. Guatemala, when they set up their screening programs, it turned out that they would have an educational session for the mothers in the morning after their babies were born. And that became so popular that they now do all sorts of education in that seminar. It was mostly for newborn screening at the time. They do hand sticks there rather than heel sticks because of supply issues. Coloring comic books. The Philippines has comic books. Mexico has comic books because the literacy rate is pretty small. And so you give people pictures, they can see the pictures, sort of understand what's going on, and in the local languages. Billboards, again, I thought this was unique until I went on the internet and found this picture of your president talking about saving the lives, improving the lives of people with sickle cell disease. And so my suggestion is that he doesn't even have to take this down. He can just change the wording to say improving the lives of people through newborn screening, save some money. Maybe that's what it'll look like in the future. At any rate, billboards are a good way to get the message across. And in some development programs like the Philippines, they show pictures of a saved baby and an unsaved baby to give the parents the idea of what to accomplish by getting the screening done. Medical support, it doesn't work if the doctors don't accept it. So you've got to get across to the physician community the importance of newborn screening. So again, here's Dr. Padilla talking to physicians about newborn screening. And here's Dr. Frimpong talking to physicians in Ghana about newborn screening as well. So you're already tapping into this one. It's just a big one that has to be done over and over and over. Here we met with the endocrinologist in the Philippines to discuss what the protocol should be. And we've met many, many different groups like this. South Africa, out in the hinterlands, they've began teaching the nurses about genetics and newborn screening. And again, you probably have something like this in Ghana. There are these outposts where nurses are the ones who are primarily there, and physicians make rounds every now and then. And so you have to show these nurses what's going on and get them to buy into the system as well. National Academy of Sciences in the Philippines, nurses in South Africa, and then even in Ghana, there's some programs working with genetic counseling and collaborations with the Association of Public Health Laboratories in the US, and I'm sure Dr. Frimpong will talk about this in a minute. In terms of technical support, these protocols are generally considered to be micro techniques, and they're a little bit different than the standard routine run in most hospital labs. The exception may be sickle cell, which is about the same. But you have to worry about support in terms of specimen collection, information, the filter papers, the equipment, and so on. Luckily, CDC in the US has a quality assurance program that works to provide laboratories with quality assurance materials, and they can subscribe to this and then be outside tested for proficiency, so that you'll know that the laboratory is doing a good job. Clinical laboratories, CLSI. Anyways, it's the clinical laboratory group, has collection material available on newborn screening. They also have other guidelines I'll talk about in a minute. Almost every program has some sort of an education brochure, often in the local language or languages. There are charts for the laboratory people to understand what a good specimen looks like and what a good specimen doesn't look like and why. These are generally in different languages. In terms of logistical support, the big problem that comes up is maintaining the equipment usually. So you have to have a company that's reliable who can supply you with help when you need it. So for instance, in Thailand, they again had trouble with getting the lancets, and so they went to hand sticks instead of foot sticks. Here's Mongolia, they're doing the heel sticks. Here's Indonesia, and here's Ghana as well. The same sort of blood collection techniques occur all over the world. I put this slide up of Uruguay to show you something which is kind of interesting. If you look at the increase in coverage, which is what those bars indicate, coverage was slowly going up, slowly going up. The president gave a proclamation in 1994, and it went up a little bit more, like doubled from the previous year, but not until 1995 when somebody realized if you linked newborn screening to immunizations, then you had a supply chain that was already there, and immediately it went to 99%. So that works in countries, especially the ones that have immunizations at birth. This is something I show when I'm in a meeting. Do you know what this is? And it's a cardboard box where you can put the specimens to dry. And I compare it to the thing that's commercially available in the center, and the one on the right is the one that these ladies made in South Africa. So you don't have to have these fancy sorts of things to make things work in your environment. If you've got the will, you can make it work. And you have to have some sort of specimen transport if you're using laboratories outside of the hospital. And so you have to think about how that's going to occur, and things like heat and humidity, how that might affect the specimen. Again, you've got to have a company that will supply you reagents and equipment support whenever you need it. In terms of policy development, eventually you get around to needing the policies to cover all aspects of the system. So there are basically 6 parts of a newborn screening system that have to be worried about: education, screening, the follow-up, the treatment, and evaluation and quality control. So again, there are manuals available on the internet from other programs that you can borrow, or you can write to me and I can put you in touch with people that you can borrow from. And the CLSI has now a new specimen collection, newborn screening specimen collection guide and testing guide for hemoglobinopathies. It just came out last year. Administration takes strong leadership, good planning, good policy development. You get good patient outcomes if you've got good functioning components in your program. So again, here's an example of what's going on in Ghana, and Dr. Frimpong can talk about that in a few minutes. Here I am in the Philippines working with the people in the community to consider how to best attack home births and get the word out to the mothers. Again, South Africa, out in the hinterlands, especially training the nurses. And in terms of evaluation, you need to consider how you're going to show that you're being successful in doing what you're doing. And so you need to develop some indicators, do some tracking. Here is an example of tracking from the Philippines. Shows when they started, how it began as a research program, what happened when the Department of Health got involved, what happened when insurance coverage got involved, what happens when they expanded the program and got more insurance coverage, and so on. So essentially, programs can work without insurance coverage, but it's difficult. We've also written something called PEAS. It's the Newborn Screening Performance Evaluation and Assessment Scheme. And this is a detailed listing of all the program components that go on in a newborn screening program in the ideal case. And you can take that and use that as a guide to develop your own system of PEAS as you move forward. There you go. So we're gradually expanding across the world. We've got US PEAS, we've got Philippine PEAS, we've got a Persian translation, we've got a Chinese translation, and Dr. Frimpong tells me that it's also being used a little bit here in Ghana. So we're trying to get people to understand that they don't have to reinvent the wheel. A lot of this has already been done. A lot of people spend a lot of money on it. Take advantage of it. So eventually, to be institutionalized, it's got to work. The newborn screening has got to work in the public health system. And while I mentioned public insurance is desirable, it's not absolutely necessary. So some development programs have been able to actually institute a fee and teach people that they can save money during the pregnancy by smoking less cigarettes, drinking less alcohol, and paying for newborn screening, which is pennies compared to other things in the hospital. Every time I get a chance, I meet with the ministers of health. So here's the minister of health in the Philippines. Here's some of the senators and representatives, congressmen in the Philippines. They enacted a law. It's not necessary in every situation to have a law, but it works in the Philippines. I've met with the Minister of Health in South Africa and other places. In South Africa, we weren't able to get things going very fast, but we were able to get it put into their genetics policy guidelines as a one sentence. However, the situation about newborn screening is going to change in the future, and we should think about it. So we saw that as opportunity. And here, of course, you've got already some opportunities going on with sickle cell disease. So a quick reality check. There's always going to be other challenges. There's going to be, you know, poverty. There's going to be overcrowded waiting rooms. There's going to be overcrowded maternity wards. This is one from Guatemala where they had 2 babies to a bassinet, and the mothers had to bring their own blanket so that they knew their baby was the one in the red blanket or the blue blanket or the pink blanket or whatever. Here's again in Vietnam, overcrowded. And of course, Philippines again, and also here in Ghana, there's some overcrowding in some places. So in summary, to be successful, you need good leadership, medical, technical, and logistical support, education of professionals, policymakers, and the public. You need evaluation tools, you need policy development, and you need institutionalization. So I hope that helps you get started on what newborn screening is and where we need to be going. And with that, I thank you for your attention, and we'll move forward with the program. Thank you. I don't know if you can hear me or not. Can anybody hear me?
I can hear you.
Okay, good.
Congratulations.
You can have control of the screen.
It's raining here in Ghana, and so we seem to be having a few delay in the transmission.
Uh-oh.
So please bear with us. Thank you very much, Prof. And thank you for the tip about taking photographs in Philippines. Yeah. Something a while away. I'm not as tall as you, though. Thank you very much for that presentation. You gave us a lot of insight, and you did mention that a newborn screening is where you have a community of people who care about improving health. Absolutely. You also mentioned that as it is now, we only have about 5% of the world's newborn being screened for at least one condition. And in Ghana, I think it is sickle cell. Right. We're very grateful again, and we are looking forward for you developing the resource for Africa Map to show where newborn screening is happening. And this will indeed be very, very helpful and supportive to our health system. We are grateful for your time, Prof.
Thank you.
Thank you very much, audience, and I hope you are enjoying yourself. Our chat section is enabled, so if you have any questions, please type them in the chat section and we'll read it out to our resource persons to respond. This webinar is sponsored by Equilinks Consult, offering psychological consulting services. As we go along, we will tell you how you can contact them should you need their services. We thank Equilinks for partnering with RDGI for such an impactful webinar. Thank you very much. Our next speaker is Professor Kweku Ohene Frimpong, and he is the president for the Ghana Sickle Cell Foundation of Ghana, and also the national coordinator for newborn screening for sickle cell. Prof will be talking to us about the National Sickle Cell Newborn Screening Program and the newborn screening policy. What are the successes and what has been the challenges? How has Prof and his team handled this? Ladies and gentlemen, please help me welcome Prof Kweku Ohene Frimpong to present his topic to us. Thank you very much, Prof.
Thank you very much, Deborah. I hope you can hear me.
We can hear you clearly, sir.
Okay. I'm going so to get started.
Yes, sir.
And I hope people can see my screen.
We can see your slides as well.
Fantastic. Okay, so I want to spend the little bit of time I have to talk about newborn screening for sickle cell disease, a little bit about the history of how it got started in the US, and also how we got the Ghana program started. Make some comments about why we screen and what we do with the babies who have sickle cell disease, the need for genetic counseling as a partner in establishing and carrying on newborn screening for sickle cell disease or any other genetic diseases for that matter. And then our experience in constantly trying to make changes to improve our experience here in Ghana. Before I go any further, though, I need to thank Dr. Brad Terrell for his extensive experience and how much I've worked with him for probably 30 years or so in the US. And I don't think there's anybody in the world who knows as much about this work than he does. And secondly, I know he may never retire, but if he's thinking about it, he could serve as my publicist. He has more pictures of me working in different places than I actually own. So Brad, I thank you very much for all that you have done. So I can't talk about newborn screening for sickle cell disease in Ghana without being a little bit personal, because my growth and life in sickle cell disease actually started a bit as a personal thing. And I'll try to be brief so that I don't look like I'm just talking about myself. So I left Prempeh College in Ghana here in 1966. And even still today, some people are not sure whether I'm the same person that used to be a track athlete or athletics for Ghana, or I am the doctor, as if we are two people. I'm actually the same person. And before I left Ghana in 1966, in secondary school, I was already running for Ghana. So people knew me. And of course, when I was in the US, I continued sports. I was lucky enough to go to Yale College. And it was at Yale that I actually heard first about sickle cell as a condition. In 1968, the Olympic Games were being held in Mexico City. And as you know, Mexico City has a high altitude. So there were some medical scientists who were concerned about how athletes who have sickle cell trait would perform, because there was some information that if you have sickle cell trait at a high altitude where oxygen levels are low, you may get into trouble. So my team manager, an orthopedist, was the first person to speak to me about sickle cell and thought that I should get tested. And so that's when I found out that I had sickle cell trait. In the long run, I didn't go to the Olympics, had nothing to do with sickle cell trait. But if you know sports history, in 1968, African countries boycotted the Olympic Games because the International Olympic Committee had invited South Africa to participate with their segregated team at the time. And so all these countries said they wouldn't go. At the last minute, they changed. But by that time, I had already started back in school, and I wasn't going to stop school to go to the Olympics. Anyway, so after college, I went to medical school, and luckily I was also in medical school at the same institution at Yale. And I got married in 1970 to my sweetheart, who also graduated in 1970, but she went to Cornell. And by that time, I knew I had sickle cell trait. And in fact, my wife was pregnant before we found out that she also had sickle cell trait. And there was a great pediatric hematologist called Howard Pearson, who was the head of the sickle cell program at Yale at the time. And so we went to meet with him, and he told us about what he was doing in sickle cell disease. He was the first doctor to screen babies for sickle cell disease in order to prevent them from dying from an infection. And Howard Pearson was trying to understand why young children with sickle cell disease die so quickly at an early age from a particular infection. And he used to say that while he doesn't have a cure for sickle cell disease, he should be able to treat infection. And so if he could diagnose these children early, he could save their lives. Well, our son with sickle cell disease was born in May 1972, and the Yale program was launched in June 1972. And Dr. Pearson used to tell people that because they knew that my wife and I were both sickle cell trait, they were expecting to test my baby. And that's how he got tested so early before the program actually launched. So here's a picture of Howard Pearson. He was a great pediatric hematologist and oncologist. And in the US and now in a few other countries, people are aware of these special camps that children with cancer and blood diseases go to mostly during the summer. The first one of these special camps was established in with money from an actor that most people grew to know. And these camps were set up, and Dr. Pearson was the first camp director for Hole in the Wall gang that was set up in the United States. And children with blood diseases and cancer used to go to. Anyway, Howard Pearson passed away in 2016, a great, great doctor. When I was going to graduate from medical school at Yale, I came back to Ghana to learn something about what happens to children in Ghana, because I always wanted to be a children's doctor, but I didn't know much about child health in Ghana because I left at quite a young age in high school. So I did my thesis work, my research work for my thesis in Kumasi, Komfanochi Teaching Hospital. After all, I was a Prempeh College student. And it was at Kumasi, this is now 1974. My son was now 4 years old, had been diagnosed with sickle cell disease at an early age, had been on penicillin, was receiving excellent care. When I came to Komfanochi Hospital, at that time mostly called G, I was studying what children in Ghana were being admitted to hospitals for. And so I was reviewing medical records going back 10 years to find out what children were coming in for, what they were dying for. And I was struck by the fact that there were very, very few young children admitted to the hospital for sickle cell disease. Now, here's a disease that everybody knew was very common in people of African descent. So you would ask yourself, why were so few babies being admitted to a hospital as large as Komfanochi? The director of pediatrics just told me that the reason is very simple. He said, you have to diagnose them before you can know that they came to the hospital with all the different complications because of sickle cell disease. So no diagnosis, no treatment. So I went back, finished medical school, and went to New York City to a hospital called Cornell Medical Center, or now called Weill Cornell Medical Center, to start my studies in pediatrics. Well, lo and behold, in 1975, New York State was the first state in America to introduce newborn screening for sickle cell disease. And here we were as interns and young pediatricians, and we had no idea what we were supposed to do with these babies. It was not something very popular public health activity around America at the time, but New York State, with very, very good public health and sickle cell doctors, decided that if they could find these babies with sickle cell disease early, as had been shown by Dr. Howard, they could put them on treatment and save lives. So my first experience, besides my own family, in newborn screening was actually as an intern and resident at Cornell. Well, I finished my pediatrics training, and then I needed to study blood diseases because now I was committed to becoming a doctor for children with sickle cell disease. So from Cornell, I went to Children's Hospital Philadelphia because I thought at the time it was the hospital that was doing the most in terms of research and treatment for children with sickle cell disease, both for what I could learn and also personally for what my child could benefit from in terms of treatment. From 1978 to 1995, the US organized the largest clinical study in sickle cell disease. It was called the Cooperative Study of Sickle Cell Disease, and altogether, there were about 4,000 patients who were followed very carefully for 10 to 15 years to try to understand exactly what the clinical course of sickle cell disease was, so that we can begin to plan how best to treat this disease. So here I was beginning my research fellowship in hematology, and the cooperative study of sickle cell disease was also starting. And so this is how basically I was growing my teeth in sickle cell disease and in hematology. And Children's Hospital was, of course, a participant in the cooperative study. That study was launched on October 1st, 1978. And believe it or not, a baby was born at the University of Pennsylvania Hospital next door to Children's Hospital Philadelphia. And that baby was the first of the 4,000 patients to be enrolled in that study. I happened to be a fellow on service at that time. And that young man, I can't even call him a young man, he's a big guy, was the first sickle cell patient that I took care of who was diagnosed at birth, besides my son, of course. So later on, when I finished my fellowship, a professor who had taught me at Cornell had become chairman of pediatrics at Tulane University in Louisiana. And he talked me into going to Louisiana to help them set up sickle cell disease programs. So we set up 2 sickle cell clinics, one at Tulane and one at Louisiana State University in a city called Shreveport in the northern part of Louisiana. So I went there to the surprise of my bosses and professors at Children's Hospital, University of Pennsylvania, because I wanted to learn how to start a sickle cell program. And also because one day I thought I would be back home to do that. So that's the personal part of my story in sickle cell in the beginning, and also, of course, newborn screening for sickle cell disease. So I went back to Children's Hospital Philadelphia in 1980 and began to, 1986, and began to work with the cooperative study of sickle cell disease and began to think about Ghana also. So the cooperative study had learned something. Young children, about 650 of them, who were actually screened at birth. And that's how that young man was found as the first patient. They followed them very carefully in order to be able to determine the clinical course of the disease in the early part of life. One of the things that was determined very quickly was the high rate of mortality from infection. So this pie chart that you see here is looking at the causes of death in children with the more common and severe form of sickle cell disease SS. And you can see in the blue part of the pie chart, 55% of deaths in the first 10 years of life came from infections. And then about 30% of them had different causes of death that were not very clear. A second cause of death that was clearly established was something we call acute splenic sequestration, when the spleen enlarges over a few hours or days and can throw the child into shock, just like a child who's bleeding. So infections clearly had been established as a major cause of death. And another opportunity for that study was to determine what is causing the infection killing these young children with sickle cell disease. And there was one particular germ, pneumococcus or streptococcus pneumonia, that was identified. This had also been identified by Howard Pearson at Yale as a leading cause of death in these children, except that the Yale number of patients was small. So this study that was supposed to learn about sickle cell disease was now faced with something they thought they should be able to do something about: a high cause of mortality in young children with sickle cell disease by a bacteria, germ, pneumococcus, that was generally treatable with penicillin, ordinary cheap penicillin. And so the cooperative study organized the famous penicillin prophylaxis study, which is still the most important life-saving study ever done in sickle cell disease. So children, 215 of them, but half of them were given penicillin twice daily, and half of them took placebo twice daily. And the study was planned as a 2-year study, but it was stopped after 15 months because after 15 months, 13 children in the placebo arm had developed pneumococcus infection, severe infection. 3 died. 2 people taking penicillin, 2 babies had pneumococcus infection, and none of them died. So the study was halted so that penicillin could be made available for young children with sickle cell disease. Well, since this infection happens to children mostly from about 6 months to 5 years of age and can kill them very fast, it became important to try to find these children as quickly as you could so that they wouldn't die from these infections, and you could try to save their lives by giving them ordinary penicillin. So after the study was published in 1986, the National Institute of Health in the US and many of the state health departments and the Public Health Service organized this consensus development conference with a simple question for the experts. Should sickle cell disease be added to the newborn screening programs that were developing in the country? Should every baby born in America be tested at birth for sickle cell disease so that those with the disease can be diagnosed early and given penicillin to save their lives? Well, the consensus panel agreed that that was an important decision to make. And so the US government began to assist state governments to develop newborn screening programs for sickle cell disease. As Brad said, most states in the US at the time already were conducting newborn screening for PKU and for a few other diseases. So adding sickle cell disease was really not redesigning an already working system. It was just teaching the laboratories running newborn screening programs to add testing for sickle cell disease, and then to develop the educational program, the treatment infrastructure, all of those things, so that these babies now could be diagnosed early and to receive care. And so that has been a great story in America. All children born in America have been tested for sickle cell disease since 2006. It took a while for these programs from 1987 consensus conference for these states to all develop programs that screen every baby. In the US, every baby, whether you're white, you're Asian, you're from Middle East, for sickle cell disease, as it is for most newborn screening programs. Newborn screening does not really seek to select some children because of what they look like or what one may think their genetics may look like. It works very well when it's universal so that you don't miss anybody's child simply because of what the child may look like or what somebody may think the child comes from. So here I was finishing my studies, come back, and newborn screening is going on. And I was now the director of the Sickle Cell Center at Children's Hospital of Philadelphia. And we had this major grant from the US government to do research in sickle cell disease. And so in 1989, 1981, as we were planning one of these research grants, major research grants, I decided it was time for me to look back home and see whether we could add a project that would be conducted in Africa, or especially in Ghana. And so in 1991, we applied for a grant from the US National Institute of Health to develop a project called Newborn Screening for Sickle Cell Disease in Ghana. In 1989, I had come home to Ghana to begin discussions about this with the Ministry of Health. And eventually, they determined that since the only sickle cell clinic in Ghana was at Kolebu, and there was none anywhere else, they directed us to go to Kumasi to try to develop the newborn screening program and a clinic to serve those children so that at least the country would have more than one. So quickly, I just want to run through this history. So we were lucky to get the grant. As soon as we were told in 1992 that we would get the grant, we established a sickle cell clinic at Komfanochi Teaching Hospital. in December. And lucky for us, the 5-year grant was renewed 2 more times. And so we were able to train Ghanaian staff, nurses, lab techs. Noguchi was kind enough to give us a lab, which we developed as the National Newborn Screening Lab eventually. And the pilot screening for newborns, newborns for sickle cell disease ran on for 15 years. Mostly in Kumasi area. It was being run under the Regional Directorate of Health and the Metro Directorate of Health, not as a research project per se, but as a demonstration project within the Public Health Service. And ultimately, we asked the Ministry of Health to help us learn how to do this in a rural area. And they picked a rural area near Ejiso, an area called Tikrom. Tikrom has 5 villages. They have about 150 babies a year. And so that's where we learn how to do newborn screening also from a rural point of view. Perhaps the most important thing that I, as a Ghanaian who had spent so much time away from home to come home and try to do something meaningful, was the formation of a group called the Newborn Screening Advisory Committee. We formed this committee to guide what it is that we were trying to do, and trying to do it in the public health service, not as an academic program, but something that the public health service needed to embrace. So the committee consisted of the chief executive of the teaching hospital, Komfanochi, the chairman of the board of trustees, and the chairman of the board at Komfanochi tended to be a representative of the king of Utumfuo. So I'll tell you that when we started this project, the chairman of the board is now the chairman of the Council of State of Ghana. So we have friends in some good places. Also, the Metro Director of Health Services, the Dean of the Medical School, the Deputy Director of Nursing in charge of Public Health. So all these important people, including President of the Sickle Cell Association of Ghana, the regional branch. That is the association that represents patients. So all these voices are needed. They met 2 or 3 times a year. Initially, they reviewed our protocol. They suggested changes we can do to strengthen the design, which we followed. And they served as a liaison between the project we are trying to run and government and the public health service. That was very important, that they shepherded this study. For whatever successes we met, I credit it to them. Now, where are we now? So we finished the demonstration project in 2008. And since then, we have been trying to get government to support this program. In 2004, anticipating the end of the US NIH funding, we established the Sickle Cell Foundation of Ghana. We were not the first organization, support group in Ghana. We formed the foundation more as a program development organization. We already had the Sickle Cell Association of Ghana, which was formed more than 50 years ago. So we have had to appeal to government to see how much they can support the program. I also had developed some linkages with colleagues in Brazil, and I had started working with Brazil for their newborn screening program, which we actually started the Ghana one before they did, for sickle cell disease at least. And eventually we signed an agreement with the government of Brazil through something called the Brazil-Ghana Technical Cooperation Agreement in sickle cell disease. They began to support some of the work that we did here, but ultimately changes in government in Brazil made it not continue to grow in strength. So in 2010, the Ghana government established the National Newborn Screening Program for sickle cell disease. And on that same day in November 2010, they launched the Technical Advisory Committee to advise the Ministry of Health on policy and a technical plan for the government to implement newborn screening as a national program. And the Sickle Cell Foundation of Ghana, primarily because we had become sort of the administrators of the NIH project towards the last 4 years of it, we were appointed the program managers to try to consolidate and expand the program, which is where we're trying to expand this program for government. All right, let me hurry up. So we did draft the policy and a technical plan that we presented to the ministry in November 1st. And some of you may be surprised that in the child health plan for Ghana, in the child health policy, newborn screening for sickle cell disease is supposed to be provided by government. That all babies born in Ghana shall be screened for sickle cell disease. That's policy. Even if we don't have money from government to do it, that's the policy. The policy addresses many programs, program oversight, scientific advisory, program coordination, healthcare provider responsibilities, parental information and right of refusal, human sample ownership and protection, confidentiality of screening information, and also the healthcare following newborn screening. So the newborn screening policy actually says the government will take care of these children for at least the first 5 years of life. That's part of the policy. And it is true, penicillin and folic acid for these young children that we diagnose in newborn screening, it's free for them, and it's been free since government became a major sponsor. So the technical plan also addressed these issues. When we were working fully, a year and a half or so ago, we were screening at 40 sites. 39 of them were in Ashanti region. And Accra, Korle Bu had started screening, not from government funding, but from a private funding from Pfizer, the drug company. Government program had stalled. A plan that was part of the technical plan to expand it into a national program over a 5-year period had stalled. And as I'm speaking to you, that plan still remains unfunded. So that's where we are. This is a picture of one of the buildings of our lab, Noguchi. And we have our small lab still using isoelectric focusing as the method of screening. And initially we had HPLC machines for running HPLC as confirmatory, but now we're changing those methods. So this is our first pilot years. We screened about 260,000 babies, and we know exactly how many babies born in Ghana now by just practical screening such a large number. We know that about 1.78% of the babies have sickle cell disease. About 53% of them are likely to be SS, and 45% are likely to be SC. I say likely because newborn screening sometimes cannot tell you exactly what the genotype of the child is going to be. You have to do some additional tests. By the end of 2018, we had screened, I'm searching for my arrow now, we had screened close to 500,000 babies, and the numbers, the percentages were basically holding the same. So from this, we've been able to estimate for government that Ghana now has about 15,000 to 16,000 babies born every year with sickle cell disease. This is how many we have. If I tell you that the United States has less than 3,000 babies born a year with sickle cell disease, it will give you an idea of how much more common this disease is in Africa, especially sub-Saharan Africa. Nigeria has close to 150,000 babies born a year. Congo DR has about 64,000 babies born a year. Tanzania, about 42,000 babies born a year. So these are very common diseases in Africa, something that our governments should really be addressing. So these are some of the indicators. We have to follow these babies very, very closely and collect a lot of information. And as Brad Terrell said, we used the PEACE program to actually design what we will do for the Ghana project in terms of monitoring the things we needed to measure and how we would track these babies. And that made it possible for us to collect all these data. I don't want to spend a lot of time with it. What do we do for a baby we pick up with sickle cell disease? It's easy. We enroll them in an established clinic where doctors have been trained to, about what to do for these babies. From about 2-3 months of age, they receive penicillin twice daily by mouth for at least the first 5 years of life. We'll give them folic acid, but folic acid, to be honest with all of you, it is not a specific medicine for sickle cell disease. It doesn't make sickle cell disease better. It doesn't make it worse, except that when the body has to make a lot of cells, like a lot of blood cells that had to be made because sickle cells get destroyed early, you need folic acid to supply some of the ingredients when you're making new cells. Now we have access to hydroxyurea for patients through a program with one of our supporters, Novartis. Now we have this large program that has several centers involved. And so when babies are diagnosed, we know what to do for them. And what we do for them is not prohibitively expensive. And so being able to diagnose them in order we can save their lives through these inexpensive interventions is really key. And it's a lesson for us and our people to be able to endorse this program. Well, sickle cell screening also calls for genetic counseling because it is a genetic disease. It's a simple genetic disease in terms of what causes the disease, how it's inherited. But many people don't know whether they're carriers. They don't understand the different types of sickle cell disease. And when we have found a baby with sickle cell disease in a family, many times they're bewildered as to how come they ended up with a child with sickle cell disease. And they don't understand why the child looks so healthy at birth, and now we're telling them about all the bad things that can happen. So whereas there are many, many people in Ghana who will counsel people about sickle cell disease, there are very few who are actually trained and certified to do genetic counseling. So we decided to develop a genetic counselor training and certification program as a support for our newborn screening program. And we did invite experts outside Ghana and experts in Ghana to become the faculty to help us develop this program. So we have friends from UK, of course, from US, and Brad mentioned that we had some support from the APHL, which is the American Public Health Laboratories system. They support the newborn screening labs and teach people how to do all these diagnoses well and monitor the patients. So they also work with us. And the Centers for Disease Control and Prevention in the US, CDC, actually gave the money to help us develop this program initially. This is the team of advisors who advised us on how to do genetic counseling in Ghana. I thought it was very important that at least what I had learned about genetic counseling, I learned it from US and other countries where you may bring a man and a woman that they're thinking about getting married, and you send them for testing and they come, and then you counsel both of them. But we know that in Ghana and in many other countries in this part of the world, in Africa, marriage is not a decision between just two people. And so family has to be part of the selection of marital partners. And we thought that we should learn something about our traditions and how we would also do genetic counseling. And so we formed this committee to advise us on how to approach it. And as you can see, if you can recognize some of the, not the people's faces, but just by what they're wearing, there's a queen mother in the front row, the woman without a blouse, she's a queen. There's a malam, Muslim malam to the right of the queen mother. And so we had people who had traditional knowledge about how Ghanaians pair up from different religious backgrounds, different cultural backgrounds. And they advised us on how I think about shaping up a program. And so from 2011 to 2014, we had several workshops. We developed a curriculum. And in 2015, we launched the program that's called the Genetic Education and Counseling for Sickle Cell Disease program in Ghana, or Genesis Ghana program. We launched it. Unfortunately, we haven't been able to hold training sessions as frequently as we wanted to, but we've done 3 so far and have trained Ghanaians. We want to continue it. So we have learned a lot about newborn screening, even if we haven't been able to scale up our program into a national program yet. But as we go along, we are guided by 2 main principles. One is to stay abreast with developments so that we don't get stuck using old methods when new methods may be better. And so we are constantly trying to learn and improve the program. Some of the changes we have made because we can't afford to do the old method, and we are looking for ways to always make it a little more affordable and therefore more attractive to government and other funders who we think want to support us. So this is the card that is used to collect blood sample for newborn screening. We don't take blood into tubes. the blood itself is collected on a filter paper, as Brad, showed in some of the slides. So we have gone through iterations of these forms. And I just want to show you the tail end of the last two. So here's a long form on which there are all these boxes to fill in. And we have to collect information about the family, not only their telephone numbers and things. We need to be able to know where they live in case they don't come when we ask them to come. Those whose babies have disease, we have to go and find them. So we ask a lot of questions about where they live, where they work, where they go to church, all of these things, so that we can use this information to track them. And that's what you see in this long form. Well, we got to a point where the simple task of attaching the filter paper to the long form became daunting for some of our printers here in Ghana. And so at some point we decided that, okay, we are going to separate the form from the filter paper. And so we shortened the form just to collect the information. And then we made a filter paper that was separate. So we put the filter paper in an envelope, we put a label on it. It has the same number label as this form. And so that when things are sent to the lab, the form goes to the newborn screen, to the data entry people, the filter paper goes to the lab. And it simplified our work. And then we didn't have to grapple with trying to get these companies to find a way to glue the filter paper to the form. It was costing man hours of work, or they were trying to do this manually. So a simple intervention, and that seemed to help us. We didn't stop there. Well, let me just show you another picture of the small card. You can see the long card versus the small card. Brad showed the South African way of trying to dry the paper. We fashioned our own way of drying it using carpenters to make wood, a box with slots on it to put the form there for drying. But you see the little card now. One thing that we decided to do very early in the program, even back in the 1990s, is that everything we do will be managed with computers for data collection. And so we designed a simple database, newborn screening database, informed a lot by the items in the peace protocol, so that we can collect information and use it to guide us in our future. Just a couple of screenshots. This is a navigation page where you land first, and then you select where you want to go and find information. This is the screening entry form. It takes information about the baby, about where the sample was collected, the baby's birth weight, the baby's gender, whether the baby was transfused or wasn't transfused, whether the baby was a twin, was not a twin. All of this information, and then about the family, and of course where to find them, is collected, and it's in our computers. As I speak, our computers have all the information about all these babies ever since we started newborn screening. Then when we get the lab results, we enter the information for the baby in the lab entry. And using this gives you a chance to sort of limit errors because we are using drop lists for entry people to select rather than typing everything and introducing errors. So that really made it possible for us. And then when we are looking for a baby, the information from the lab is sent back to the screening sites, and the nurses who do the tracking can print forms that has all the information about the baby, where to find the baby, and then the bottom of the form on the right, which looks like it's something that needs to be hand-filled, is taken by the nurses who actually most times end up walking around to find the exact house that the baby parents live in. And then they have to use this form to record the outcome of the tracking, whether the baby was found, given an appointment to the clinic, and all of that is recorded. And this information is then entered back into the database so that we have more complete data. Now we have advanced a little bit beyond that. I and others always working hard to summarize the information in the community, find in entry. And once a nurse wrote something by hand, and now the form has traveled to the lab and data entry people, some missing information cannot be found. So a simple thing, for example, the baby's birth date was entered wrong, so it looked like the test date occurred before the baby was born. Well, you can't go back and find those babies and ask them what was the correct birth date. I wrote it wrong. And so your data collection, that is going to tell you how long it took from the day the baby was born until the sample was drawn and the sample was tested in the lab. It's something we track. If the birth date is wrong, the whole setup, that data chain, then is wrong. So we decided to go one step up, to design an app, a mobile application, instead of using paper to enter the data, a mobile application that can actually force you to recognize your errors and correct them. So if I'm writing today's date as the birth date, and I wrote a date that was another date, it will tell me, no, repeat it. You repeat it and you give the wrong date, then you know you make an error. You have to correct it there and then. If your test date that you are entering is before the birth date, the app will recognize it and tell you, no, you cannot have a blood test done before you are born, not for newborn screening. And so you have to go back and correct something. So the app brought efficiency in data collection. I was concerned that the app was also going to introduce something that maybe the nurses would not like. You know, they're good at writing things on paper. Would they want to use this app? Well, when we were finishing the development of the app, we actually had designed a program where they will use the app for 1 week, then go to paper for 1 week, then come back to the app for 1 week and go back to paper. Design all of this on paper. Well, we found out very quickly. They did the app and decided they're not going back to paper. They're not doing the second week because it's a lot more efficient. And so now we don't use forms. Our information is collected on a phone-based app. Here's the baby, mother, taking the information, and the nurse is entering everything on the app. And that has really simplified what we do and reduced the errors that we make. And also the app, because it's basically hooked into a network of computers, it's a database in itself. All the information that goes in the app gets stored. So a few screenshots from the app. Let me just move quickly because I've spoken too long. So where are we? Well, a few successes. We've established the technical capability for newborn screening in Ghana for sickle cell disease. And someone will tell you, we can use the same system to add other disorders. We don't need to develop separate newborn screening programs for all the different diseases. Brad told you that there are centers screening for 50 disorders in the same lab using the same team of lab technicians, and efficiency and cost saving makes all of this possible. We have incorporated the newborn screening program into the public health service in Ghana. It's not sitting outside as a little research project. And if we had the resources, every baby in Ghana should have been screened by now, should be screened based on national policy. It hasn't happened yet, but this is where our advocacy needs to be strengthened. We have introduced some innovations to improve efficiency and in many cases to reduce the cost of what we do. Challenges. Our greatest challenge is still not just Ghana's alone, but we have been unsuccessful in getting Ghana and other African governments to recognize the significance of newborn screening as a major child health intervention. So we are all struggling to get our countries in Africa to take sickle cell disease, newborn screening seriously as a way to save lives of very young children in Africa. No country in Africa can tell you how many children die from sickle cell disease in the first few years of life. And if you don't have that information, newborn screening for sickle cell disease seems like something that is not needed. Because if you don't know these children and they die, how do you know the impact they're having on your child mortality? We need to learn how to generate public advocacy for newborn screening in Ghana and in the rest of Africa with all my colleagues. So on behalf of all the babies that we have pricked, whose heels made them cry, but especially on those that we found who have sickle cell disease, who have been enrolled in care, some now as old as 23 years of age, I thank you very much for your attention. Thank you.
Thank you very much, Prof. I especially appreciate your personal journey, your personal path into the work of sickle cell disease in the country and spanning so many years. I mean, it is inspirational. And personal stories always add that touch to presentations. And we are very grateful that you were able to share that personal story with us. I picked up that the New York State was the first state in 1975 to initiate newborn screening in the United States. You were able to establish newborn screening lab here in Ghana in partnership with Noguchi. And in 2004, the Sickle Cell Foundation Ghana was established. What I loved about your presentation is the emphasis you placed on the fact that folic acid does not make sickle cell any better or worse. Rather, it helps in the reproduction of the red blood cells. It is important to know that. I am very grateful for sharing. We've learned so much, and I'm sure at a later date, Sami and I would definitely visit you for more. I have a personal interest on how your path has taken and see how I can also take that path. Thank you very much, Prof, for sharing. We have a few questions.
Welcome. Thank you.
So, if it is okay with the rest of the speakers, I would just like to read some of the questions we have received so far so that you can address them specifically. We have, I think he's a doctor, Shyamala P. Sapati from India, one who said he's very much a rare disease advocate. So how can he help? We are trying to get his details so that we can speak after this webinar. But his first question is, at what point is the newborn screening initiated in a newborn's life? At what point? Is it right after birth, the first week, the first month? At what point is the newborn screening done? And how many conditions can be identified? Is it only sickle cell as at the moment? My understanding from your presentation is that Ghana is currently screening for sickle cell only for the newborn screening, but I guess Doc wants to understand whether this is like general for everywhere or specifically to Ghana.
Okay, if I'll try to answer part of that question, and then actually I'll ask Brad to also share in. As far as sickle cell disease screening goes, it doesn't have to happen at birth right away. We want to do it at birth only because the baby is available. Many babies are born at a place, and it's easy to just get a sample than to let them go home and then try to see whether they can come to another place to be tested. Mm-hmm. In Ghana, our experience is that we have screened maybe 70% of the babies at where they were born, and the other 30% when they went for their first immunization. Because the babies in Ghana are given this baby health card, the book, and we have a stamp in it. We have a line in it about newborn screening where the baby has been screened. If you are screened, your book is stamped.
Okay.
So if you show up 2 weeks later or a month later at an immunization site and there's no stamp in your book, the nurses know then to screen you. So for sickle cell, it is really just trying to get all of this done before the baby is 2 months of age. That's when we want to start treatment. But I want Brad to comment on some of the metabolic diseases where you want to get the sample in relationship to feeding.
Right. So
the timing there is different and is crucial.
Yeah. Right. So
Yes,
every
Brad.
condition sort of has its own golden period. And many of the metabolic conditions, it's the first couple of days of life. It used to be the case that you had to wait till after they'd been fed, but now most of the testing is such that it picks up the baby anyway. So in the U.S., almost every program screens. Can you hear me? Almost every baby is screened after 24 hours. The exception, California screens after 12 hours, and a couple of programs still screen after 48, but almost every program has now moved to 24 hours. And it's been shown time and time again that the tests work. It's a question of, you know, which diseases need things quicker. And so that 24 hours has sort of become the gold standard in the States because we do so many different tests. So it's a compromise. Some things need to be done early, some things can wait a week or so, but 24 hours is generally the case. And you were talking about India. The big push in India right now is for hypothyroid, and hypothyroid needs to be treated by a couple of weeks of age in order to be effective. So if you screen at 2 days and then you have to repeat to make sure that that's the right baby, you know, it needs to be done shortly after birth and within the first couple of days after birth. So, Kof, I have a question for you. Is there a
Yes.
follow-up confirmation test after the screening?
Yes, originally we were using HPLC as a second sample. So when the baby reports for the first clinic visit, which we want it to happen by 2 months of age, then a second sample is taken to confirm the initial finding. We think that that's important because first it establishes the identity of the baby. Right. That is the correct baby. There wasn't any mix-up of samples or mix-up of writing results in the lab, anything. It confirmed that this is the baby. And also it gives you a chance to begin to do some genetic counseling because that early, often both parents may show up and you begin to, even to be able to test the parents if necessary in order to explain why this child has this type of sickle cell disease rather than another type. But the method that we use for second sample used to be HPLC, and the HPLC method that we have in the equipment is very expensive. So our machines broke down, we couldn't afford it. So often we're just using the same initial test for the second, but ideally you should use a second method. Yeah. Right. That's because of the variety of hemoglobin.
Thank you very much, Prof. and Prof, if I can say that. we have some of our audience raising their hands to ask questions. We are having technical challenges having you ask your question directly. So please, if you can type your question in the chat section, I will read it out to the resource persons so that they can respond until we are able to resolve that technical challenge. Thank you very much, Prof. At this moment, what I heard from the response you gave to Dr. Shamila Pisapati is that it is very key, especially for sickle cell disease, to do the screening before the milestone of 2 months old. And then for other metabolic conditions, it is imperative that the child is screened within the first 24 hours of life because most interventions work when they are administered very early in the child's life.
After 24.
That's right.
After 24 hours, because some
after
of
24 hours.
Yeah, some of the tests don't work so good. Yeah.
Yes, so sir. Thank you for the correction. So for other metabolic conditions, the screening is done after 24 hours. Right. And this all points to the name of the screening exercise. Really, it is newborn. So it must be done as soon as everything is ascertained that the child is well to be able to carry on the other required tests to assure that indeed they are well and well to be discharged home. Thank you very much. And now we will proceed to our next presentation and presenter, even as we continue to take note of the comments and questions that are coming in. Our next presenter is Dr. I'm trying to get your name right. It sounds like Dr. Mam.
Yeah, exactly.
All right. Dr. Mam Joy, and she's from the Philippines. Dr. Joy is a licensed physician and also with the Institute of Human Genetics from the University of Philippines, Manila. She's also a genetic counselor, and she's talking to us about the role of genetic counseling in newborn screening. Ladies and gentlemen, please help me welcome Dr. Mam.
Thank you. Thank you, Deborah, for that kind introduction. And thank you also to the organizers for inviting me to this webinar. So, okay, can you see my screen now?
Yes, we can, Dr. Mam, we can see your screen.
Thank you. So I was invited to talk about the role of genetic counseling in newborn screening. This is my outline. I will talk about genetic counseling, a little about newborn screening, the role of the genetic counselor, and a little about the Philippine situation. So according to the National Society of Genetic Counselors, genetic counseling is the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. It is a communication process which deals with the human problems associated with the occurrence or risk of recurrence of a genetic disorder in a family. So the process integrates the following: the interpretation of family and medical histories to assess the chance of disease occurrence or recurrence, education about the inheritance, testing, management, prevention, resources, and research, and counseling to promote informed choices and adaptation to the condition. So genetic counselors are health professionals with a master's graduate level of education and is experienced in the areas of medical genetics and counseling. They work in research, laboratory, industry, academe, and advocacy positions. Genetic counselors work as members of the healthcare team. They have many roles, such as designing and conducting research, managing clinical cases, supervising trainees, teaching, making healthcare policy, developing and implementing educational tools, and some also work in administrative capacities. So the scope of clinical practice of genetic counselors varies within and between countries. Frequently, genetic counselors are part of a multidisciplinary team in obstetrics, pediatrics, oncology, cardiology, neurology, ophthalmology, and metabolic clinics. In Europe, the European Society of Human Genetics has suggested that the term genetic counselor should be a protected professional title, referring to a health professional who had been educated and trained at master's level to enable them to develop the core competence defined for the role and to practice according to the code of ethics. So what do genetic counselors do? In terms of counseling, they provide supportive counseling by identifying families at risk and providing information and support to families who have members with birth defects or genetic disorders and to families who may be at risk for a variety of inherited conditions. They also do interpretation, meaning they investigate the problem present in the family, interpret information about the disorder, analyze inheritance patterns and risk of recurrence, and review available options with the family. In terms of education, they serve as patient advocates and refer individuals and families to community or state support services. And they also serve as educators and resource people for other healthcare professionals and for the general public. So this figure represents the global estimate of trained genetic counselors in 2017. As you can see, the biggest group can be found in the Americas with around 5,000 genetic counselors, followed by in the Europe and Middle East with around 1,000 genetic counselors. Asia has around 350 genetic counselors, and closely followed by Australia with 300 genetic counselors. And there are less than 50 genetic counselors in Africa. Historically, the word genetic counseling was coined by a geneticist, Dr. Sheldon Clark Reed, in 1947. And the first master's degree genetic program in the United States was founded in 1969 at Sarah Lawrence College in New York. So we now go to newborn screening. It was mentioned that newborn screening is a public health program aimed at the early identification of conditions for which early and timely interventions can lead to the elimination or reduction of associated mortality, morbidity, and disabilities. So the newborn screening programs began in the early 1960s with the original work of Dr. Robert Guthrie, who developed a screening test for phenylketonuria and a system of collection and transportation of blood samples on filter paper. Countries include newborn screening as a standard of care, covering a wide range of conditions, and the genetic counselors can provide care for the families affected by these conditions, such as endocrine, metabolic, hematologic, immunologic, infectious, and other conditions. So the newborn screening is actually more than testing. It should be a part of a system that includes screening tests, follow-up, diagnosis, treatment, and evaluation as necessary. And the primary objective should be to ensure that every newborn receives appropriate and timely services. So it is composed of evaluation, including outcome monitoring and quality assurance as an important component that encompasses the system. Screening, including proper timing and specimen collection, transport, laboratory testing, and reporting. Management, including counseling, treatment monitoring, and long-term follow-up. Early follow-up, including abnormal test notification, tracking, and confirmatory testing. And diagnosis, including clinical and biochemical evaluation. And inherent to each of these components is an education process of health professionals, parents, the general public, and even the politicians. So generally, there are several roles that a genetic counselor can do to help families understand the significance of genetic conditions in relation to cultural, personal, and familial contexts. So they can identify the needs of the individual or family and use an emphatic client-centered approach to the provision of genetic counseling. So the counseling focuses on understanding, accepting, and adapting to the genetic diagnosis or risk and their impact on the individual and family. It also includes a discussion on the patient's understanding of what causes the disease, the scientific explanation for it, and the patient's interpretation of his or her condition. They can also explore the role of personal beliefs and cultural and religious beliefs and their role in the adaptation, and help promote feelings of personal control and mastery over a genetic condition. So counselors also collect, select, interpret, and analyze information, including family and medical history, pedigree, laboratory results, and literature that is relevant to the delivery of genetic counseling. As a side note on the family history, genetic counselors use standardized symbols in creating the pedigree. Family history is a powerful screening tool because it holds important information about an individual. It can be used as a diagnostic tool and help guide decisions about genetic testing for the patient and those family members that can be at risk for the same condition. If a family is affected by a disease, an accurate family history will be important to establish a pattern of transmission. The family history can also identify potential health problems such as heart disease, diabetes, or cancer that the individual may be at increased risk for in the future. And early identification of increased risk may allow the individual and the and their health professional to take steps to reduce the risk. For example, by implementing lifestyle changes, introducing medical interventions, or increasing disease surveillance. Genetic counselors also provide education about inheritance, testing, management, prevention, resources, and research to relevant individuals or families. They can assist in choosing educational materials for the parents and other healthcare providers. And they can also be responsible for the development of these resources or have developed them in partnership with other newborn screening professionals. Um, Genetic counselors also promote informed choices and psychological adaptation to the condition or risk of condition. So with proper genetic counseling, families will be provided with important information and a better understanding of the medical recommendations and options that are presented to them, which can help them to make informed and sometimes difficult choices and adapt to the condition or risk that is identified through newborn screening. They can also help the family understand the medical management and treatment, and so that the families can be involved in making the best decision that is possible for their child. Genetic counselors also apply their expert knowledge to facilitate the individual or family to assess the appropriate healthcare resources, including medical diagnosis and resources for management of the condition. The genetic counselor can serve as a central resource of information about genetic conditions for other healthcare professionals, patients, and the general public. Genetic counselors also do psychosocial counseling. So this is actually a balancing act of trying to reassure the family while at the same time decreasing their anxiety. And they can help individuals and families identify the psychosocial tools that will be helpful to them to cope with the potential outcomes. And often, the patient list can further extend to actually include siblings, the extended family, and their offspring. So it is important for the medical health provider who is providing the counseling to keep in mind that the family as a whole is the patient and multiple members may depend on the information that they are providing. This point of view gives the provider a unique perspective and fosters patient care and communication. And another goal of the psychosocial counseling is to increase the family's understanding of a genetic condition and decrease the misconceptions surrounding it. They can also discuss the options regarding disease management and the risks and benefits of further testing. So newborn screening in the Philippines started actually as a research group in 1996, and it became mandatory when the newborn screening law was passed in 2004. Named the Republic Act of 2004, Republic Act 9288, it institutionalized the comprehensive newborn blood spot screening. So when newborn screening was started in the Philippines, we started testing for 5 conditions, namely congenital adrenal hyperplasia, congenital hypothyroidism, G6PD deficiency, phenylketonuria, and galactosemia. And then in 2012, MSUD or maple syrup urine disease was added to the panel of disorders. And in 2015, the expanded newborn screening was started, wherein we started testing for 28 disorders, including amino acid disorders, organic acid disorders, fatty acid oxidation disorders, endocrine disorders, hemoglobinopathies, urea cycle defect disorders. So our coverage, unfortunately, in 2018, as of 2018 was close to 80% because we have a lot of home deliveries and we are having difficulty in capturing those home deliveries. So as of December 2018, this is the prevalence of disorders of the conditions tested in our newborn screening. So we provide genetic counseling actually to those patients who tests positive for the hemoglobinopathies, since the confirmatory test for these disorders involve DNA mutation analysis. We provide pre-test and post-test counseling to the parents of these screen-positive newborns. So the newborn screening program's efficiency and effectiveness depends on the smooth integration of sample collection, laboratory testing, follow-up diagnosis, timely treatment, and tracking of the outcomes. Included in the workflow is the counseling of the patients from the time that the family receives the call that their baby has a positive result in one of the disorders tested to the time that the diagnosis has been confirmed is actually a very scary time for the families. Feelings of anxiety, stress, and sadness are very common, and genetic counseling can help alleviate these feelings in order to help the family cope about the newly diagnosed genetic condition in their child, which will hopefully lead to better outcomes for the patient. So the referral flow in our newborn screening program is divided into short-term and long-term follow-up. The short-term follow-up includes the time when the newborn screening test is administered, to the recall of screen-positive patients, to undergoing of confirmatory tests and confirmation of the diagnosis. Once the patient has a confirmed diagnosis, they are transferred to the long-term follow-up team in the newborn screening continuity clinics. Currently, we have 14 newborn screening continuity clinics all over the country. In the short-term follow-up flow, the first session of genetic counseling can take place upon the disclosure of diagnosis. At this point, we help the families understand what the condition is, answer their questions, do psychosocial counseling, and help them to cope with the diagnosis. And in the long-term follow-up flow, the sessions of genetic counseling can be done at any time, over time as needed. For example, if there are patients who are not following their treatment or management plan, they can be referred for recounseling, wherein we try to explore the reasons for their non-compliance. Or maybe the couple is thinking of having another child and they are referred for counseling in order to discuss the disease inheritance and risk recurrence and reproductive options. So there are actually 14 graduates of the Masters of Genetic in Science of Master of Science in Genetic Counseling from the Philippines. So the program started in 2011, currently with 14 graduates as of 2019, and there are currently around 20 students under the program. So the program is a 2-year degree program that prepares the students to become competent genetic counselors. And the program will serve a vital role in the access, delivery, and expansion of medical genetics, not only in the Philippines, but also in the Southeast Asian region. So, the take-home points are to center the care. Genetic counseling is actually about centering the care around patients and their families. And the role of the genetic counselor in newborn screening is constantly evolving as technology and therapies continue to improve. Assessment of psychosocial and emotional status is equally important. And we should remember that genetic counseling is a process that happens over time. Sometimes the family coming back for more sessions or recounseling. And genetic counseling is not a routine process. It's different for every individual and for every family. So I would like to acknowledge the following persons, Chancellor Carmencita Padilla, Ms. Kevina Dahoyag, and Ms. Angela Pasqua. And these are my references, and thank you for your attention.
Thank you, Dr. Mam. That was quite enlightening. The role of genetic counselors in newborn screening exercises around the world. And I am so happy to learn today that the genetic counselors actually explore the role of belief systems of clients and some ways somehow inculcate that into counseling them to accept and come to terms with whatever possible conditions they are looking at. And it is quite impressive that in 1996, you only started with 5 conditions, I live with G6PD, and I only found out about it when I was pregnant with my child. And
Oh,
so it's the opportunity of getting to know and probably adapting lifestyles right from childhood. And so I am very grateful. And to think that you actually added on more disorders up to 20 in 2014, that's quite impressive. And Ghana, we are holding this conference now. We have Prof, and we now have relationships with you. We are learning, and we hope to explore this partnership that Rare Disease Ghana is establishing with all the resource persons today. Thank you very much. As we wait for questions and proceed to the next, we have some questions for Prof. Kweku Ohene Frimpong. So Prof, if I could please go ahead and ask you this question. Our chat box is buzzing with questions, and we are very excited about that. We have a question from Madam Otiko Jaba. She was a former minister for Ghana, and she's asking whether the sickle cell disease screening is mandatory in Ghana. Secondly, why are the figures of sickle cell disease much more in places in Africa than in places like the USA? I think, Prof, you explained that, but maybe Madam missed it. So if you can recap for us. And then lastly, how affordable is the screening exercise? I'll come back with the second question if you can, because it is equally loaded. Thank you very much.
Thank you very much. Can you hear me?
Yes, we can hear you, Prof.
Okay. Madam Jaba, I'm really quite impressed and honored to be answering a question from you. I'm really thrilled. First of all, the thing about price, we've never charged for newborn screening in Ghana. There's no established fee, and all the screening that has been done has been free of charge. I think that's a hesitation that we face from governments. We've been asked about doing screening privately in some of the private institutions. We still haven't developed the mechanism for it. Now, sickle cell disease, now we know that sickle cell disease, or the change in our gene that resulted in sickle cell disease, originated in Africa. It originated in Central Africa or West Africa about 7,000 years ago. And it took a few more thousand years before the effect of that genetic change actually became known. In Africa right now, and certainly in Ghana, children, young children die from malaria more than older children or adults. That's the case with malaria. Most children who die from malaria are less than 3 years of age. Today in Ghana, in Nigeria, in Tanzania, a child who is AS is less likely to die from malaria than a child who has regular blood, AA. Babies and young children with AS are protected from severe malaria. And so, over generations of these 3,000, 4,000, 5,000 years, those children who are AS, living in a part of the world where malaria kills so many children, survived malaria, grew up to have children, some of whom would also have AS.
Yes.
And over thousands of years, these AS people, all of whom originated from one ancestor, now become strangers and they marry each other. And so you may have two AS people marrying each other, one AS, one AC, and then sickle cell disease developed in this part of the world. It just happened that where malaria was killing so many children, where this gene had an advantage to protect them, the people who were living here were dark-skinned. But the gene itself is not linked to dark skin at all. About 2,000 years ago, the sickle cell gene crossed the Sahara Desert, which at that time was not this impassable desert, and went into North Africa, and then went over the Mediterranean into all the countries around Mediterranean Sea. And so Italians, Greeks, Cypriots, Spanish, Portuguese, skin whites have sickle cell gene. Over into the Middle East, every Middle Eastern country has the sickle cell gene. And most people in the Middle East, as you know, are not Black. It goes all the way to India. And now we even have reports of a few Koreans whose sickle cell gene is traceable to even to grandparents without them having ever left Korea to go live anywhere else. So the gene was only helping babies survive malaria. And it didn't matter what your skin color is. As long as you lived in a part of the world where malaria was still killing children, it was an advantage to have one copy of the gene. Unfortunately, if you get two copies of the gene, one from each parent, then you have a disease. And so that's the unfortunate byproduct of a gene that actually helped children survive. Yes, thank you.
Thank you very much, Prof. This is like sickle cell 101. We are so grateful for the way you have taken your time to even break it down for us, the non-science background participants, to really grasp the meaning of what you're sharing with us. We are grateful. I have another question from one Mr. George Kwablaga, and he wants to know, this is quite scientific, so let me read. He wants to know if the newborn screening for sickle cell disease is still relevant if the two parents have the genetic makeup of their hemoglobin known through quantitative hemoglobin electrophoresis. I think I got it.
Quantitative hemoglobin electrophoresis.
Yes,
so the question he's asking is, should newborn screening for sickle cell disease be applied to all babies, or should it be applied only to babies who, by knowing what the genotypes of their parents are, cannot have a baby with sickle cell disease? It's a very important question.
Yes.
But this is public health. You know that if all children were not immunized, they will not all get the diseases for which we immunize for. Some, by their own genetic makeup, may be able to withstand polio or may be able to withstand something. But the infrastructure you need to have in place to determine the hemoglobin genotype of every man and every woman, you will spend a lot more money and resources tracking that information and then making sure that when a baby is born, the parents' results are available for you to decide that we will test baby A, but we won't test baby C because we have the results. We know that baby C's father is AA and the mother is AA, and they don't have beta thalassemia and they don't have all of this. And so this has been tested, actually. It's been evaluated in one of the states in the US. And the conclusion is that newborn screening works as well as it does because it is applied to all the children. You don't have to spend a lot of money and time and resources doing all these additional tests in order to determine it. But if somebody truly knows that he and his partner, in fact, from the screening that they have done privately, cannot have a child with sickle cell disease. If the two of them, none of them has the S, you cannot have a child with sickle cell disease. So there are situations where if people truly on a personal level can make that decision, yes, they don't need to be tested. But at a public health level, trying to get a father and a mother and their testing result to decide which baby should be screened, it costs a lot less to just take a small sample from every baby, put it through machines, and find those with the disease. So you don't have to do the detective work of trying to determine who goes and who doesn't go.
Thank you, Doc. I have another question for you, and it goes like this. Given the great success of the sickle cell program by Ghana, what can you tell us about the points to consider in initiating a broader newborn screening program for other hemoglobinopathies and congenital or metabolic anomalies, and how to go about which disease to prioritize for the screening? And this question is coming from Madam Priscilla Abina Echan. Thank you very much, Priscilla, for your question. Prof.
Thank you very much, Priscilla. You know, when the policy committee was formed, one of the provisions was that the Ministry of Health would form a National Newborn Screening Steering Committee.
Mm-hmm.
That would be the body that will examine changes in policy to maintain the technical advisory committee to try to improve the technology and the science of screening. So if those committees had been maintained, you could see that that would be the committee from where advocates would go and press for additional disorders to be added to the National Newborn Screening Panel. So that they would take the information, the specialists especially can come with data to show why it's so important to add congenital hypothyroidism to newborn screening for sickle cell disease, because that condition is also common in this part of the world. And if you already have the infrastructure, for one thing, it may not cost that much to add. But that committee was never empaneled, and so the government is not gaining the advice and the advocacy from that committee. We are still pressing for the ministry to institute that committee. I think that it's important to look at successes around the world and see that there's a lot that others have learned, and we don't have to crawl through those same things. The methods, nobody has designed methods just to spend more money than necessary. Sometimes you mention an expensive machine and people say, oh, we can't afford it, we can't afford it. But the expensive machine can do so many tests that you end up in the end saving money. So I think that if we have a committee that monitors this for government and the public health service, people who are very knowledgeable can come together and make decisions.
Great. Thank you very much, Prof. Prof, do you want to add?
Yeah, I want to make a comment. You heard Ma'am's talk about the Philippines. This question came up, it comes up everywhere. What do we add next, and how much does it cost, and what do we have to do a pilot? And this is kind of interesting because when they did the expansion in 2014, they didn't have the funds to look at conditions in detail. So what they did instead was looked at the literature coming from the states where they were separating out populations. So for instance, in California, there were data on Filipinos in California, and there were sufficient data to show that even if they did cystic fibrosis screening, they would probably pick up some cases, but definitely they did alpha thalassemias and that sort of thing. So they were able to get around part of this conundrum about how do you pay for a pilot screening, and do you need all these pilot data? Again, though, they have an advisory committee, like Kof said, and that advisory committee was quite willing to look at these data, put it together, and then make a recommendation to the government. So it's important to get an active advisory committee to get these sorts of things moving. But it's not necessarily the case that you have to do a pilot on everything. There may be sufficient data around that can convince you that this is a worthwhile condition to add.
Great.
Great. A quick addition to the answer. I left. The question also asked whether we can have testing for other hemoglobinopathy. That means other abnormal hemoglobin conditions.
Yes.
The tests that we use detect not just sickle cell hemoglobin. It detects all the common abnormal hemoglobins. Some things we cannot detect in newborns, a condition such as beta thalassemia. We don't have a simple test that shows it up in a newborn, but it can be done later on. And particularly if a parent is known to be a carrier, we can do other tests when the baby is getting older. The reason sickle cell diagnosis needs to be done early is because of the treatment. We need to start it early. But we see other abnormal hemoglobins by the methods that we use. So we diagnose, like in Ghana here, we've diagnosed more than 3,000 babies with CC. CC is not a sickle cell disease, it's a very mild blood disease, but it's a byproduct of what we are looking at for. So we diagnose that also and counsel and treat the families. Yeah.
Thank you very much, Prof.
Mm-hmm.
Thank you very much, Prof. And we are grateful to all the 3 presenters so far. In fact, at the end of this webinar, I'm sure most of us will call ourselves pocket and newborn screening experts. And we are learning so much. This program is sponsored by Equilinks Consult, offering psychological consulting services. We will provide details as to how you can reach them should you need their services. Our next presenter is, I'm just checking whether we still have some questions before we move on to our next presenter. Hello, Hanif. Great, I see him in the chair, so I can quickly introduce him. Hanif, you're welcome. Our next presenter is the head program lead, diagnosis program, Rare Disease Ghana Initiative. And he would be talking to us about screening for rare inherited metabolic disorders, the Rare Disease Ghana Initiative Newborn Screening Projects. Ladies and gentlemen, please help me welcome Mr. Hanif Ahmed Emisa. Thank you. Contact details. Hanif, you are muted. We can't hear you.
Sorry about that. Sorry about that.
No,
okay.
No problem. No
so
problem.
Good afternoon to everybody. And then I'm very grateful for the opportunity and to join in to share what we have here as Rare Disease Ghana Initiative, what we have that we intend to bring on board to help screen all newborns, possibly in Ghana. All right, so my presentation is going to look at a few things about the background or some of the issues that we have going on with regards to neonatal deaths around the world and what we have happening in Ghana, the situation of the newborn screening programs that we have in Ghana, and that I wouldn't waste much time because Prof. Mahini Frimpong has done a marvelous job in that area. And then I would come in to talk about the Rare Disease Ghana Initiative Newborn Screening Program that we look forward to start. And then I would briefly introduce the screening tests panel that we have. And then I may go on to talk about some possible challenges, which Prof. Bradford is already elaborated on that, but I may share some few thoughts on that. And then go on to talk about the medium to long term strategic plans that we have to help make this a success. All right, so as we have already heard, newborn screening is recognized all over the world as a public health measure to help detect some conditions which, lead to abnormalities in the growth and then disturb the healthy growth of children. And that it's instituted in most developed countries, and in some developing countries, you see some of these programs ongoing. And according to the World Health Organization, we had a total of 284,000 new neonatal deaths, which were recorded worldwide. And then it's also known that an estimated 303,000 newborns die within 4 weeks of birth every year worldwide due to congenital anomalies. Yes, so out of this number of deaths that we have about 94% of this number occurring in low and then middle income countries, which falls in the bracket of developing countries. And in Ghana, it is known that we have a total estimate of 25,000 neonatal deaths which were reported in 2015. And out of this number of deaths, neonatal deaths, we have 10.3% of this deaths being due to congenital anomalies. But as we know, like Ghana, like most developing countries, does not have a national newborn screening program which supports the screening of newborns for these congenital anomalies that we have or we would be making mention of. All right, so I would be skipping through this particular slide. I think Prof. Ohin Frimpong has already made mention of some of these points, so I would quickly move through and then talk about the Rare Disease Ghana Initiative Newborn Screening Program. All right, so the aim and the vision of this particular program is solely to institute a newborn screening program which seeks to screen all newborns in Ghana. And then we have far advanced preparations, and we are in some discussions with some diagnostic laboratories in Ghana to look at how they can assist us in screening the newborns for these congenital anomalies and metabolic disorders. And we look forward and anticipate to screen babies for free. That is our aim, and we are looking forward to some partnerships with some multinational companies and a lot more companies so that we can make this. And ultimately, we look forward to doing this with the Ministry of Health and making this a national program so that it could be accessible and open to every newborn who is born in Ghana. So basically, like Bradford made mention of, we look forward to collect samples by the use of the filter cards by the dry blood spot sampling technique. And then once that is done, we are going to link up with the diagnostic facility so that the samples can be properly stored and then transported to the laboratories for the respective laboratory assays to be conducted. And once we have the test results ready, we would have the clinicians or the caregivers being notified. So first of all, we're going to do this by phone and mails, and then subsequently we would have the detailed laboratory reports being given to the clinicians so that the necessary treatment and management protocols can start. And we look forward to implement the program in 2 phases. So quickly, let me take us through some of the conditions that we look forward to screening for. And Prof. Ohin Frimpong is made mention of hemoglobinopathies and specifically sickle cell disease. We look forward to screening for hemoglobinopathies. And then also amino acid metabolic metabolism disorders. And popularly, what we have in most countries would have the phenol ketonuria being instituted and as part of the national newborn screening program. Maple syrup, urine disease also in there. We look forward to also look at congenital hypothyroidism, congenital adrenal hyperplasia. We look forward to also talk about or screen for galactosemia, GSPD or glucose 6-phosphate dehydrogenase, which is one of the very common conditions that you have around in Ghana. We also look forward to screen for some organic acidemia, and then urea acid defects or disorders, and then permitting cycle effects. Yes, so quickly back to the phases of the program. And in phase 1, we look forward to partner with the 4 major teaching hospitals that we have in Ghana. And we have started some discussions. We would be meeting the head of the neonatal unit of the Congenital teaching hospital to discuss the issues with him and how we can kickstart, and with the rest of his entire team, how we can kickstart. Dr. Coleman, we look forward to meet you and then discuss this and see how we can do this over the period. And with the first phase, we look forward to screen 100 babies in these 4 major teaching hospitals, and we intend doing this over the period of 6 months, like I said. And in total, we anticipate screening a total of 2,400 babies by the end of the first phase of the program. Yes, so after the program is completed, I mean, in the first phase, we would do some evaluation and then monitoring alongside us with the program goals, as I mean the phase 1. Once the evaluation reports and the monitoring reports are ready, we would publish the result of the screening program that we have done for the first phase. And then from there, we would look at discussions with stakeholders to revise guidelines and strategies pending the recommendations that are going to come from the reports of the committee, the evaluation and monitoring committee. All right, so in phase 2, the program seeks to expand to screen 7,200 more babies. And this time around, we are going to include the other regional hospitals. And this time around, it is not only going to be the teaching hospitals. We look forward to rope in the regional hospitals. And here you have, I forgot to make mention of the fact that we have actually 16 regions now in Ghana, but technically we have this regional facilities in the existing 10 regions that we had already. And that once we have the other regions having their regional hospitals, we would look forward to bring them also on board and look forward to screening babies who are giving birth to in those facilities as well. And in all, the project seeks to screen a total of 9,600 babies yearly. All right, so now let's quickly look at some guidelines for the program. And for the program to be administered, a formal request would have to be placed by the clinician or the physician who is attending to the baby at birth. And that will be done through the newborn and the Rare Disease Ghana Initiative website. That link will be created and published on our website. And you can visit that website once the program is initiated, once we start in the first quarter of next year. And that children who are more than 6 months, the test would be conducted, and it would take place when the healthcare provider, the physician or the clinician of the patient, makes a formal request to us, sent through the link that we have here. All right. So, like I said, we're going to use dry blood sampling or the filter card for the sample technique. And this will be taken by trained staff, which we intend to have a training program for our healthcare practitioners who will be partaking in this program in the last quarter of this very year. We having plans to do that once we finalize discussions with our laboratory partner. And the first sample we look forward to be taking after 24 hours, within 24 to 48 hours, or possibly after 3 to 4 sessions of breastfeeding. And then a second sample we look forward to be taking within the period of 1 to 4 weeks of life. All right. And if the samples, due to some conditions, will have to be taken before 24 hours, a second sample will be taken within 72 hours, but not later than 2 weeks. So the informed consent forms and all other biodata which will be collected and have been properly filled will be sent to the Rare Disease Ghana Initiative Office, and then subsequently the link up with our laboratory partner will take the dry blood spot samples to the laboratory for the laboratory assays to take place. All right, so what are some of the possible challenges that we look forward to facing? I think Prof. Bradford has also made mention and is spoken about most of these issues, and I wouldn't also waste much time on this particular one. Yes, so all right, so now to the medium and long-term plans that Rare Disease Ghana Initiative has to make this particular program a nationwide one, and also much accessible and also affordable to everyone. We look forward to advocate that the private health insurance companies that we have, and also the national or the public health insurance schemes that we have, would capture newborn screening as part of their premiums or the services that they are going to render to people who enroll on the scheme. We also look forward to liaise with the Food and Drugs Board to register and license available orphan drugs, which may not be licensed and available for use in Ghana. We look forward to do that with the food regulator, the Food and Drugs Board, so that that will also be made possible, so that once a condition is screened and is detected, the necessary available drugs that can be administered and proper management can be given to the patients. And we also look forward to partnering with food processing companies to look at how we can make the processing of special feeds and then formulas available for sale, so that once we have babies who have some of these metabolic conditions which have or need to be on special diets or special formulas, we can have some of these things available for them to use. And also possibly like Professor Ahine-Frimpong and Professor Bradford made mention of, we would get in touch with the Association of Public Health Laboratories, so that we can look forward to some continuous or continual quality assurance and proficiency testing programs for the laboratories which will be involved or will be partaking in the program, so that we are sure of the quality and the reproducibility of results. Also, we look forward to partnering with the Ghana Health Service and then the Ministry of Health to make this a nationwide program. And we look forward that once the time comes and once those discussions kickstart, we would still fall on some gallant members who have made a lot of strides in these areas. Professor Akinfo and his team, we would have them on board to help us make some of these possible. We also look forward to institute or put in place an advisory board which would come in to look at issues of how the going forward with regards to this particular program is going to be. Do we have to add on some disease conditions, or we may have to take some others off, or some of the technical issues? So here we look forward to draw people from academia, people from practice, from the respective health professional backgrounds, so that they can bring in their technical advice and make some of these, make this program a success. And also, already I'm aware, and through Prof. Ohinefen's presentation, the Association of Public Health Laboratories and the CDC, together with some other international partners, have already started some genetic counseling programs where they do some trainings and issue out certifications for persons who enroll on the program. We look forward to make some of these programs, specifically the genetic counseling, institutionalized, so that we can have parents who are yet to even deliver, go through some of these programs and then get the best out of it. And thank you very much for joining us. Thank you very much. All right, over to you, Deborah.
Thank you very much, Hanif. Thank you for your presentation, and again, telling us the great strides that RDGI is taking to make newborn screening available to Ghanaian babies moving forward. We have a series of questions. I'm sure as Dr. Mam responds, we would begin to maybe get questions for you, Hanif. So I would just go straight and present Dr. Mam's questions to her. And Dr. Mam, great.
Yes.
How are you feeling, Dr. Mam?
Yes, I can hear you.
Great. So the first question we have for you is, what is the criteria, the entry criteria for the MSc in the genetic counseling? The second question, let me just read that. And the question is, do you use single sample for all the 20 or over 20 newborn screening exercises, or you take multiple samples? And what is the cost implication for caregivers and parents? This is from Abdul Razak Sani. Again, this is to all the presenters, so I'm going to ask it so that after Dr. Mam has finished speaking, all of you can chip in. We have a question again from a very active participant, Priscilla Abina Echam, and she's saying, can presenters, that is yourself, our resource persons, also share with us some of the ethical challenges that you have gone through, especially with the ethical review boards, because some of these things, human subjects and everything, how do you go through all of that? And as well as the patient and for parent consent. Please, did you get the question, or should I read again? Share with us some of the ethical challenges that you have met in the space of your work, and the ethical review board, patient and parent consent. Can you please share from your experiences with us, so that as Prof. Thirell put, reality check, as we are getting excited about these all these new projects, we also get to see the challenges that may be ahead of us and plan accordingly for them. Thank you very much.
Okay, thank you for that question, Deborah. So, regarding the question about the what is the requirement to get into the master's degree program? So actually, we only require a bachelor's degree. We would prefer a degree with a science background because the master's program is heavy on genetics and the concepts. No, but we actually can accept anyone with a bachelor's degree.
Okay.
And as for the, I think I can answer some of the questions regarding the samples for the 28.
Yes, please, the sample.
So actually, we only use one filter card, and since we use this equipment called the tandem mass spectrometry or MSMS, so we are able to test multiple conditions with only the one filter card. So with the four circles. And
All
then
right.
about the with regards to the ethical implications, so our program started as a research group, so I think they needed a some ethical clearance for that, and then they had the data, and then when the law about newborn screening was passed, um, consent was not required. So actually, because of the law, the newborn screening was mandated. Consent was not required, and if some parents refuse to have newborn screening done to their children, they would have to opt out of the service. They would have to sign a waiver of um, they would have to sign a waiver that they do not want the newborn screening to be done to their children.
Okay. Have you had situations where parents have opted out?
Yes, I think there have been situations like that over the years, mostly because of religious reasons. So we have
Mm.
we have a religion that they do not want anything to do with blood. So any tests or any blood transfusions, they do not want anything to do with it. So they refuse to do those tests.
Oh, okay. Okay. All right, Prof.
Yeah, I have a couple of comments. Regarding the specimen, you saw the cards that Koff showed. There are multiple circles on a card usually, anywhere from 2 to 5 half-inch diameter circles, basically.
Mm.
And so in most US programs, they require you to send 4 or 5 of those circles filled. In the Philippines, maybe it's 3 or 4. Koff showed 2. But anyway, the point is that you can't just use a machine to take one little punch and think you can do everything.
Mm.
Mass spec, for instance, will do maybe 20 different conditions out of one little 1/8-inch diameter circle punched out of the paper. But if you're going to do hemoglobinopathies, you got to take another punch to do hemoglobinopathy. If you're going to do G6PD, it may require another punch. If you're going to do thyroid, it may require another punch. So some things can be grouped together depending on the manufacturer of the test kit, and others can't be. So just because you've got one little circle there, you can't do everything from one little circle. You have to have multiple circles on your card. Now you can do everything from one card, but not from one little circle. Okay.
Mm.
So it is fine to take one sample, multiple circles, and send it in. And I'm saying again, in the U.S., many programs use 5 circles. And so when a physician says, "I can't take that much blood from my baby," they can. Okay. That's one thing. Now the other thing is regarding.
Well, I know about doctors taking too much blood from sample from a baby. I have a son with Down syndrome, and I remember in the early days, and you go to the hospital and they keep on taking these vials of blood. And as a parent, I was so worried, I was so anxious. But eventually I understood what it was all for, and well, we are grateful. So,
Yeah.
Prof,
This,
I know you were explained that even in Ghana, you have used the filter paper to find other conditions other than sickle cell. So you seem to have alluded to that response already, but if you want to add more, we are grateful.
Can't hear you,
Prof,
Carl.
you're muted. Prof, you're muted, please. That's okay.
You know, newborn screening and the amount of blood that it uses is really one of the more impressive scientific developments, that you can test for 50 or more disorders on a few drops of blood that come to the lab on a dry. It's really remarkable technology. And so, I mean, when we started, we were using forms that were originally designed in the US with 5 circles. In our just economy, we couldn't afford to buy US samples cards after about a year or so with the NIH grant. So eventually, as we started making them locally, and as I showed you, eventually we decided to use the small cards. As soon as we start adding disorders, we will make the card bigger. The savings clearly just that we save filter paper size. That's all. We can cut a sheet of filter paper into more small cards when we use the 2 circles than if we use a 5 card. But when we add more disorders, we will use more filter paper. So that's entirely doable. As far as the issue about ethical review, when we started our project, it was a research project, and there had been no newborn screening here. And so the advisory committee, I asked them that question as to whether we needed to get consent specifically for it. And they wanted to know what had been done elsewhere. And I said, most states in the US, you don't require specific consent, but the parent is given the right of refusal, so that you don't have to sign a paper that says, yes, I want my baby screened, but that you can just say, when they ask you, you can say, no, I don't want my baby screened. And as far as I know, in Kumasi, I think there's been only one case of a mother who actually refused to have the baby screened. And so we use the same thing. The policy states that, yes, it's a mother should be given the right to refuse, but that they should be asked for permission to do the test. And if it says no, then you don't do it. But you don't just go stick a baby without the mother knowing that that's what you're doing. So we don't require specific consent. Now, Hanif, I just want to suggest something to you. I think later on we need to sit down and talk about how best to develop the program. We store as many of the filter paper as we can. So at Noguchi, at any one time, we have 40,000 or more in cold storage. Why did we do that? Well, there's material for DNA for different purposes, and it's in the policy. It says that if a scientist wants to have access to any of that for any research, they should apply through the Ministry of Health, and they can do it. So if you wanted to do, for instance, sentinel screening, just to see how frequent any particular condition is in the Ghanaian childhood population, you can just have access to all these samples without going to the babies first. Once you determine the frequency of it, then you can design one where you are actually using it. And as we talk, you realize that you don't have to have a parallel screening program. You just need to teach the lab to add a test to the sample that they already collect. Otherwise, the infrastructure for collecting samples and all of that becomes multiple, and you end up making it too complex and too expensive.
Okay. Thank you very much, Prof.
Sure.
We'll come to you for much discussions in this particular.
Further comment regarding that. So some of the states in the U.S. have been taken to court over this consent and storage issue. So it's not a trivial issue. Because now that you have a sample, lots of things can be done to it. So some states in the U.S. now require consent to save the sample. They don't have no consent to have the test done, because that's the law that says it has to be done, and that's to protect the baby from the parents, in fact. But there is a question of storage and use, and so that has to be clarified in your policy. The other thing is that the devil is in the details. This is a special kind of filter paper. It's not just any filter paper. That's number one. So you got to be careful what you order. And number two, you need to be sure that the laboratory doing the testing is in some sort of external proficiency testing program, perhaps from the CDC. That's the one I would recommend, but there's also one in Europe, because otherwise these tests are not exactly the same as they would do in a hospital laboratory. They may be close to it, but they're not exactly the same, because now they're punching an 1/8 of an inch diameter blood spot and working with that rather than a tube of blood. So you need to be sure that you get that worked out in the details.
All right. Thank you very much. Okay, and if you want to say something?
Yes, I think that I'm very grateful to my senior colleagues here who are making very impactful and deep inputs into the program already. And we look forward to still come back to them to discuss a lot more issues to make the program even much more successful.
Thank you. The exciting thing about it all for me is that it started in the US about 1975. It started in the Philippines in 1996. And guess what? It started in Ghana in what? When the Sickle Cell Foundation of Ghana was launched in 2004, I guess. So we are making
the project started in 1993.
Imagine. I was in secondary school. So
you're so young.
I was.
So Kof and I actually go back almost that far, because shortly after it started, there was a newborn screening seminar in Corpus Christi, Texas, and
yes,
somebody from the program in Ghana presented at that session on educating physicians. They've done a survey of the physicians, the knowledge level in physicians, to show that the physicians need to be trained first.
That's true.
Yeah.
Right. So for me, what I'm saying is that newborn screening would one day become like we don't have to go through this hassle, because I'm looking at the history that has been enacted for us here today, and you look at the progress we are making. There is learning, there is sharing, there's collaboration, and it's only better for future children. That's all I can say. I want to say thank you so much to all our resource persons for coming. For our audience and our guests, we apologize for our last speaker not being able to show up. We only got to notice at last minute that he will not be able to show up. But I think our hours, 2 hours, 3 hours here has been filled with so much resources that we need to sit down and reflect and see how we can be part of this movement. I am so grateful to you all. And like I said, this partnership is only established, we can only move forward together. Thank you for coming. Thank you for sharing your knowledge with us. And thank you for allowing me to moderate this session. Very grateful. And now I hand over to Mr. Samuel Wiafi. But before he comes in, I want to remind all our audience that we were sponsored by Equilinks. Their details, how we can contact them, is in the chat box. So please reach out to them if you want them to partner us again for such impactful programs in the future. And we need more partners. So if you're on this platform, you render any kind of service, and you want to be part of the rare disease movement so that we can make more impact, please reach out to us and we'll be glad to partner with you. Thank you very much. And I hand over now to Sami for the closing remarks. It's been an honor to moderate this session. I'm grateful.
Thank you, Gary.
Hello, can you hear me?
Yes.
Yes,
We can.
Yes. I want to thank all of you for making the time for our webinar. In fact, this is the second time we are doing a webinar, and so we're still learning. And so we sincerely apologize for any technical hitches and any challenges you might have encountered on this program. There are a few things I want to touch on before we end the webinar, and those are to answer some few questions that Prof asked. The first question has to do with why is RDGI not integrating with the already ongoing NBS program for sickle cell disease? And I want to say that what we presented is a proposal or an idea we have to be able to expand or to augment the existing newborn screening program. We have no intention of creating a parallel system for newborn screening. And so it's just an idea of what we hope to add on to the existing program to be able to expand the scale up the number of disorders that are being screened, looking at what is being done elsewhere, and be able to increase the number of disorders that could potentially be screened. And so the suggestion regarding the filter papers that have been stored at Noguchi seem to be a very laudable idea, and so it would be a good idea to go back and retest those and see other conditions that we may get from it, and potentially use that to pull out a certain number of data, amount of data that will be significant to decide which conditions should be included on a newborn screening or not. And so to answer that, we are not creating a new system. It's the old system. We're going to work with the old system and going to expand the old system to make sure that we have a huge coverage. Our goal is also to be able to draw in more partners on board from different areas, because there may be partners who are interested in JCSPD, but since we are not looking into JCSPD, they may not be willing to be on board right now. But then if we expand, you're able to have all of them come on, and then in that way we'll be able to pay or get a sustainable financing system for this project. And so that is why we are looking in that. The other question is, what happens if disorders are detected without access to treatment? This breaks the fundamental rule of newborn screening program. Yes, it is very important. It's one of the issues that we have always thought about and have always looked into. And so right now, the disorders that have been put on that we have looked into for newborn screening are the disorders that are mostly, some of them that require maybe dietary adjustments and other behavioral or some modification. If detected early, we'll be able to find some treatment for them. And we're also hoping to expand the access to treatment. I work with the on the treatment access committee of the EDEC, International Rare Disease Research Consortium, where we are proposing for expansion of the access to treatment for rare diseases. And so there are certain these treatments that we have proposed must be available through advocacy. We are hoping that these patients should be able to access these treatments. And in addition to our treatment access program, we'll be able to support patients who need certain treatment. And the good news is that the FDA in March 2018 published the guideline for registering of the orphan products here in Ghana. And so we are fortunate to be one of the few countries to have, in Africa, to have an orphan drug guideline or an orphan drug guideline in place for assessing rare disease products. And so this is encouraging and very positive. And so we hope to also leverage on that and be able to help patients who need access to these treatments. And so these are some of the few ideas that are in place, but as I said, most of them are still in the planning state, and we've not started rolling them out yet. We are mobilizing resources and still doing the necessary consultations and being able to talk to the right people, the right network, the right persons. And when we have everybody on board, then we have the resources, we will start implementing this project. And we are doing this because we are a key stakeholder in the newborn screening and in rare diseases. And so we think we have to also help to push it to whichever level that we can, and potentially see it to become, just as it has been in other countries, the most successful public health intervention in the country. And we look forward to that. Okay, so on that note, I want to thank everybody, the speakers, Prof. Bradford. You know how tough it is to get you, but we are grateful that you made the time. Prof. Rempong, we are honored that you, out of your busy schedule, gave us the hearing and offered to speak. And Dr. Malm, it should be other time,
1 a.m.
midnight in Philippines, yeah, but you stayed up to be with us. We are very, very impressed. And Hanef has been very instrumental in helping to write out, reviewing all the policies, the guidelines, the documents, and being able to help us together with Dr. Yada Kwan put together our guideline that was shared with you, and we're still reviewing it. And so we'll definitely come and see you, Prof, and sit down and see how best we can put everything together and not duplicate the resources. And so we are honored. And for our listeners and attendees, we are very grateful that out of your busy schedule, you made time to come and learn about newborn screening. And we know that you'll be able to send a message across to whoever was unable to join. And together, I believe that if we are all asking that our children should be screened, our government will have a very little option regarding policy and regarding laws. And so let us all send a message out there. We can save babies, we can help prevent long-term disabilities, and ensure that we can all achieve the sustainable development goals, which is critical, SDG 3. And so let us all continue to work together. And please, we may reach out to you one way or the other on other issues that are relevant to our community, and we hope that you would honor our invitation. Thank you so much, and I look forward to seeing you all some other time, somewhere.
Yep.
Thank you.
Thank you.
Thank you very much for the invitation. This was great.
Thank you.
Thank you.
Okay. All right.
Good night, Ma'am.
Bye-bye.
Bye-bye, everyone.
Bye.
Bye.
Bye-bye.
Eugene.
Eugene, can you end?